In neurosurgery, we are going to talk about this today. Is a 6 years old man presented with ataxia and gait disturbance and headache together. On MRI, there is a fluid around the brainstem and around the peripontine and cisterna magna. This kind of fluid is suspicious. You may see this in the DuralAVF or angioblastoma. There is no tumor in the cervix, and therefore focus on MRI. This is very important preoperatively to look closely at the MRI, not only the brain tumors or hydrocephalus or arting, and anatomy of vasculature is very important. And you see here that there are veins. These are veins that surrounds the brainstem and fill the cistern, and it is a very clear sign that tells us that there is abnormal fluid here. This abnormal fluid means that the blood passing here by high velocity or high volume, and therefore we have a vascular tumor, a diffuse AVF or a small AVF or AVF. And the follow-up, we perform angiography for this patient that the presentation was gait instability and headache. An angiography that Dr. Sohail Nadri done. Okay, he will describe this angiography very well, and you will see what happened. This is not an overemphasize. Every cerebral angiography should be injected in 6 vessels. There is nothing as 4 vessel cerebral angiography. Angiography for diagnosis of vascular pathology should be done in 6 vessel mode, because there are many cases that can be discovered only through the injection through the external carotid. Please, what you found there?
This is the DSA angiography of this patient. So here we can see the injection of left renal carotid artery. As you can see, this is the occipital artery which goes all the way, and here is the area which we can see all the fistulas coming out of the left external left occipital artery. This is the fistulous area, and here starts the venous system of the fistula. These are aneurysms within the venous system which go all the way draining to the peripontine vein here and premesencephalic veins, and refluxing into the cortical veins, going all the way up and then draining into the superior sagittal sinus, and then to the transverse and straight sinus, and going into the jugular vein.
This is a HighFlow DuralAVF.
Very high flow DuralAVF.
Comings and fed by the left occipital artery. And their drainage was
both anterograde and retrograde drainage, this is very important because it has reflux into cortical veins, which is this shows it's a very high grade dural fistula, and it's very prone to venous both ischemic and hemorrhagic.
Yes, therefore these kinds of fistula, when it was the most dangerous one, are having the cortical drainage. The cortical drainage happened through the retrograde filling of the cortical veins. And what happened to the anterograde drainage systems?
As you can see here is the injection of the embolic agent, which in this case was Onyx, As you can see, this is the injection within the nidus of the fistula. This is the, as you can follow, the penetration of the embolic agent inside the nidus. We have, when treating these kind of malformations, you have to go as far as you can within the nidus and do the injection inside the nidus, and then you have to penetrate to the vein. As you can see, we will penetrate inside the vein here. This is the venous system, in order to achieve the maximum efficacy of the treatment. This is the venous system. So here you can see.
You see the injection phase that Dr. Sohail inject the Onyx, and he was able to go far as can possible to reach to the foot of the veins. And foot of the veins, yes, means the beginning of the venous problem. And it is the most important location, should be covered by the injection of embolic area and the post-op angiography.
As you can see, it's the injection inside the left external carotid artery.
استوب بزن. روی استوب باید کلیک کنی. روی پلی و استوب. بغلش بزنی میره بعدی.
This is the occipital artery. There is no remnant of the nidus of the fistula. This is the rest of the external carotid artery, and that's the reflux inside the internal carotid artery.
Please describe this. Come back. This is the internal carotid artery, and this is the external carotid artery, and this is the occipital artery that were large before the injection, and now
here was the site of the nidus.
Yeah.
This is the AP view of the post-operative angiogram. There is no remnant of early draining veins, and as you can see, we have the normal venous anatomy here now. No early draining vein. Normal cortical veins here, draining into the superior sagittal sinus. This is the transverse sinus and occipital sinus. And here you can see the post-op MRI. No remnant of those.
It is very good that Dr. Sohail performed early MRI. Comparison with the previous large T2 needed, large T2. This is the postoperative MRI. You see all of the vein that we saw previously around the brainstem with high flow void now is disappeared, and
they have collapsed.
They have collapsed, and it is very good to perform this early MRI. The patient's symptoms is going to be better, got better and better, and there is a chance that this dural AVFs open again or no?
There is a little recurrence rate, less than 10%. That's why we will do an angiogram, a follow-up angiogram within 6 months.
Yes, every moment that you be closer to the venous side of the dural AVF, the chance of closure is higher. When you inject far in the artery, you may disappear the AVF, but it comes back certainly. But if you go near the junction of the arteriovenous fistula, the chance of the recurrence is going to be lower and lower. But what was the classification of this dural AVF soil? What we call it? For example, we call it tentorial dural AVF. We call it sigmoid transverse dural AVF.
It seems to me like a transverse sigmoid dural AVF.
This is a classic sigmoid transverse dural AVF. This is a classic one. First, in the many years ago, before creation of intra-arterial embolization, I don't remember exactly who introduced it first. Embolization intra-arterial. I don't remember. It was around 1950 maybe. But before that, they opened the dura over there and coagulate everything around the sigmoid sinus. There was a classic surgery for this. And now it's very better. You can inject everything and finish the job. Therefore, recapping our talks today is being curious about the symptoms in the elderly patient. Don't attribute it to the senile complaints. Always seeking for something. Special vascular pathology, insufficiencies, DuralAVF, all things like that should be considered. Another important thing is looking carefully around the MRI corners. Maybe some vessel, some shadow will help you to reach to the good diagnosis. And the third point of view, the treatment of DuralAVF should be, the diagnosis should be carefully performed and treatment follows very carefully. And you know the chance of the cure is high. And the neurological symptoms, at least the patient has tinnitus. The tinnitus, when the patient has tinnitus, should go for the treatment and finding this, and it is very important. Thank you.
Thank you very much.